Thank you all for coming. Thank you for the introduction, Heather, and special thanks to Carl for sharing his story with us all here today. The title of my talk is FASD at Midlife, What Have We Learned? So after today's talk, it's my hope that you'll all be able to describe emerging research on mental health and substance use in FASD, identify physical characteristics and conditions associated with FASD in midlife, and recognize areas where middle-aged adults with FASD show similarities and or strengths compared to their peers without FASD. I have no conflicts of interest to disclose. So I want to start my talk today by noting that fetal alcohol spectrum disorders are young disorders. And by that I mean, compared to many, many other health conditions, they haven't been formally recognized for a very long time. Only a little more than 50 years ago, a certain pattern of effects of prenatal alcohol exposure on children really began to be widely discussed when a landmark paper was published in the esteemed medical journal, The Lancet. Many of you are undoubtedly familiar with this origin story. 8 unrelated children of mothers described as, quote, chronic alcoholics who all reportedly, quote, drank excessively throughout their pregnancy were reported to have a similar pattern of birth defects, growth deficiencies, and developmental delays. Naturally, this gave rise to an impressive body of research on the effects of prenatal alcohol exposure in children and adolescents. And this research enabled us to realize that prenatal alcohol effects occur along a spectrum, not only in terms of severity, but also in terms of which bodily systems are most impacted from person to person. So as a result, most would probably agree that the big picture of fetal alcohol spectrum disorders is incredibly complex, and we're still learning more about FASD every day. Fairly quickly, it became apparent that the effects of prenatal alcohol exposure can be lifelong, and that means that FASDs are not disorders only of the young. It's understood that children affected by prenatal alcohol exposure grow up to become adults affected by prenatal alcohol exposure. But only 50 or so years on, we still don't fully recognize or understand all of the health impacts in early to middle adulthood and beyond. Adults with FASD, as we've heard here so far, report an array of sometimes mystifying health concerns affecting the whole body, including but not necessarily limited to cardiovascular, metabolic, sensory and neurological, bone and joint, immune system, and mental health disorders. Many have noted that certain conditions seem to affect individuals with FASD at younger ages than they affect others. For example, arthritis seems to affect people with FASD at a younger age. If you're here last year, you may have attended a powerful session in which the FASD Changemakers and Adult Leadership Collaborative presented on their Lay of the Land survey number 2. Their survey findings highlighted the impact of FASD and related health conditions on quality of life in adulthood and pointed to the need for more research attention on physical and mental health in adults with FASD. So why is it important to know about this? Well, we need to develop a wider understanding of risks associated with prenatal alcohol exposure. And that's going to enable us to improve clinical care for affected individuals. It'll help us identify areas where an early intervention in a disease process may be most effective to limit incidence or severity. And ultimately, what we want to do is improve quality of life. So how can we learn about health impacts of FASD in adulthood? There are a variety of different ways that all have their strengths and inform our growing understanding. One way is to survey a large number of individuals with FASD with a questionnaire, like the Lay of the Land surveys. It's also worthwhile to conduct interviews and focus groups and write up case studies and firsthand accounts. And biomedical research informs the picture by examining biomarkers of health conditions like inflammatory or immune factors to see if they differ in groups of individuals with and without FASD. Sorry, I lost my place. Okay, now why are controlled studies important? Controlled studies help us to learn about health impacts of FASD in adulthood. They help us refine our understanding by taking into consideration other factors that may come into play besides PAE. There are those that may be directly related to the question of impact of prenatal alcohol exposure on health, like timing and dosage of exposure. Now, in studies of adults, we often don't know this. On a basic level, we can compare those who we're pretty sure were exposed to others who were unexposed. We may have some indication of the severity of exposure or severity of alcohol impact, like the presence or absence of characteristic facial features associated with FASD. We can ask, for example, if people with more severe manifestations of FASD that were evident in childhood are more likely to have certain health conditions. We can also look at factors that are indirectly related to FASD, like different levels of childhood adversity, stress in adulthood, or socioeconomic status. For example, we know that people with FASD often experience higher childhood adversity, so if we find that adults with FASD are more likely to have a certain health condition, might that be due to their FASD or to their childhood adversity? We need to unpack that. And it's also important to consider factors that are unrelated to FASD, but may be related to the health condition we're studying, like gender, race, or ethnicity. For example, we know that women are more likely to have autoimmune diseases. How might that clarify or complicate the picture with FASD? So our multi-site team is conducting controlled studies with middle-aged adults with and without prenatal alcohol exposure, or FASD, as part of the Collaborative Initiative on Fetal Alcohol Spectrum Disorders, or CFASD. Now, being at this meeting, you're likely familiar with CFASD, but for those who may not yet be, CFASD is an international collaborative of basic behavioral and clinical investigators who are conducting research on FASD. The collaborative seeks to bring together researchers from around the world, in part to facilitate studies that perhaps couldn't be conducted at any one site due to lack of access to enough participants with FASD or people with FASD from diverse backgrounds. As part of the fourth iteration of CFASD, or CFASD-4, our multi-site team at the University of Washington, Emory University, and University of British Columbia enrolled middle-aged adults in Seattle, Atlanta, and Vancouver. So the lead researchers on these studies are listed here. And actually, several of them are giving talks here today. I also want to acknowledge important contributors to this research. Nope, wrong way. Okay. There's some noteworthy differences between the cohorts. The Seattle cohort consists of individuals with FASD diagnosed at the University of Washington with fetal alcohol syndrome or fetal alcohol effects in childhood or adolescence, using the diagnostic terminology that was in use at that time in the 70s, 80s, and 90s. They're mostly white and American Indian in terms of race and ethnicity. The Atlantic cohort consists of individuals who were born in the 80s and whose mothers had documented prenatal alcohol use. These individuals had dysmorphology examinations done in childhood, but were not specifically diagnosed with FASD. And this cohort is mostly African American. And the Vancouver cohort consists of individuals with FASD diagnoses who were recruited from the community in adulthood. And I believe they are mostly white and American Indian as well, like the Seattle cohort. So each of these cohorts has at least one control group of individuals without significant prenatal alcohol exposure, and ages range across the three cohorts from about 35 to about 65. Now, not all sites assess all the same things, but when we do, we hope that the findings of our studies are clearer and stronger. But as research sometimes goes, this is not necessarily always the case. So I want to just talk about our general study methods. In Seattle and Atlanta, past research subjects were contacted and invited to participate in Tier 1, which involved completing a series of questionnaires, including a survey of their health conditions. Now, in Seattle, this was done almost exclusively via phone, since many had moved away since they participated here in Seattle in their youth. And I believe the Atlanta site had more local residents. A subset of folks came back for Tier 2, which involved things that need to be done in person, like a blood draw, cognitive testing, and dysmorphology examination. At the University of Washington, many people participating in Tier 2 also had brain imaging. So the health survey was a self-report survey that was based on individuals' knowledge and understanding of their own health status and diagnoses. We didn't look at their medical records. They were asked a comprehensive panel of questions, up to 190 items, depending on skip patterns that were used to skip over irrelevant follow-up questions. And these items were largely adapted from the behavioral risk factor surveillance system used by the CDC. Additional items were developed by the research team. Domains assessed included healthcare access, vision, hearing, sleep, weight, dental health, cardiovascular health, neurological and mental health, endocrine disorders, immune and autoimmune disorders, cancer, stomach, digestion, kidney, bladder, and bowel problems, and adverse childhood experiences. Item formats generally were along the lines of, do you have any problems with ... Or have you ever been told by a doctor, nurse, or other healthcare professional that you have ... We also assessed substance use. One way was by administering the Alcohol Use Disorders Identification Test, also known as the audit. This is a 10-item self-report questionnaire that mostly asks about alcohol use in the past year, but also has a few questions about lifetime alcohol problems. We also administered a drug checklist developed by the research team, where for each category of commonly used substances, participants were asked if they ever used the drug, if they were currently using the drug, how frequently they used the drug, and wherever it made sense to do so, the amount of drug they typically used per occasion. Participants seen in person completed a urine drug screen and a blood draw that examined a biomarker of heavy drinking called gamma-glutamyl transferase, or GGT. There was also a mental health survey in the form of the Psychiatric Diagnostic Screening Questionnaire, which assessed current symptoms of major depressive disorder, PTSD, anxiety and panic disorders, OCD, substance use disorders, and psychotic disorders. Our measure of cognitive functioning was the NIH Toolbox Cognition Battery, administered via an iPad, which computes a fluid cognition composite score and includes the dimensional change card sort task, the flanker inhibitory control and attention task, list sorting working memory test, picture sequence memory test, and pattern comparison, processing speed. Dysmorphology examination was conducted with a standard dysmorphology exam in which the examiner was unaware of the participant study group. And the measures included occipitofrontal circumference, palpebral fissure length, philtrum length and lipometer, and vermilion border lipometer. And as I mentioned, at the Seattle site, a number of participants also underwent brain imaging, specifically magnetic resonance imaging, or MRI, examining intracranial volume, regional cortical and cerebellar gray matter, white matter, cerebrospinal fluid volumes, and volumes of subcortical regions of interest. This work was led by Ed Riley, Eileen Moore, and Amanda Bischoff-Greta. Now, I'm going to be vulnerable for a minute and confess that this is my brain right here. So as the saying goes, if you see something, say something. Or actually, don't say anything. I don't want to know. Moving right along. Awkward. So in terms of data analyses, we use various methods depending on the research question, but we're always looking for between groups differences, and in some cases we use propensity scores. Typically we're taking demographic variables like age and sex into consideration and looking at interactions with group membership. So now, as I move to talk about findings from our studies, I'm not going to spend time getting into the details of the numbers. This is not an audience consisting solely of researchers, as you all well know. Probably no one is going to remember the numbers anyway, and I wouldn't necessarily want you writing them down because they're not the be-all and end-all of adult FASD health research. I mean, the findings are some of the best, or in some cases, the only ones we have, but it's important to keep in mind that these are some of the first studies with relatively small samples, and they're not population-based. That being said, if you really want the numbers, come see me, or pick up my business card at my exhibitor table, and I'll happily email you a PDF of any of our articles. Okay, so this is where we published our findings on self-reported health outcomes, and I do want to give a shout out to Claire Coles, who will be talking more about this in her presentation tomorrow. So our study found that compared to controls, people with PAE reported more frequent problems with certain things. Their hearing, teeth, and skin, gastritis, heart problems, thyroid problems, diabetes and cancer, kidney stones and bladder disorders, and seizures. Now, some of these may be a little scary, but remember, I want you to take your takeaways with a grain of salt. And we don't normally tout non-findings, but for balance, I think the non-findings are important to mention here. We found that PAE and people with PAE and people without PAE reported comparable frequencies of problems with vision, sleep apnea, high blood pressure, high cholesterol, heart attack, stroke, autoimmune disease, allergies, asthma, arthritis, HIV, and hepatitis C. Now, some of these may be a bit surprising. I, for one, was a little surprised about arthritis because that's one where we hear reports of people with FASD having early onset arthritis. Now, it's important to mention that we didn't ask about age of onset for most of these problems, and it may be that by the time they got to the age they were in our studies, people without FASD caught up to people with PAE or FASD in some ways, but that's only conjecture at this point. We need to do more studies to replicate these findings and develop our understanding further. So for now, let's just note that in multiple areas at midlife, according to our data, people with PAE or FASD are looking very similar to their peers. Okay, so here's where we published our findings on substance use, and this is our most recent paper. The take-home messages here in our study were that compared to controls, people with PAE reported higher levels of adverse childhood experiences, but no higher rates of recent negative stressful life events. In fact, those with PAE and dysmorphological features had lower rates of negative stressful life events. And this could perhaps be due to some of these participants being a little bit more sheltered. While people with PAE had higher rates of current tobacco use, these participants had lower rates of current alcohol use. And considering all the harms that can come from alcohol use, you might say that, in this way, folks with PAE were doing better than their peers. There was an indication that participants with PAE were using cannabis at higher rates compared to the national average, but this may be related to the location of our study sites. Now, I don't know about Atlanta, but you may have noticed that cannabis use is pretty common here in the Seattle area. I mean, heck, even our local scientists are stoners. Thank you for laughing. If this science gig, when it runs its course, I might try a career in comedy. I'm literally here all week. So there were no differences between groups in current or past use of other substances, which is especially noteworthy considering the higher levels of childhood adversity. So here again, we have an indication that in a certain way, people with PAE are doing better than we might expect. Okay, so this is where we published our findings on mental health. Our study found that compared to controls, people with prenatal alcohol exposure reported higher levels of current depressive symptoms and prevalence of diagnoses of depression, anxiety, bipolar disorder, and ADHD. Most of us are probably not surprised about ADHD, considering how commonly FASD is mistaken for ADHD. Now, higher rates of anxiety and depression are also perhaps not surprising, considering the stigma faced by people with PAE or FASD. And bipolar disorder diagnosis may be a reflection of depression that comes and goes. Now, this is not to minimize the significance of these mental health concerns, but to contextualize them and offer possible explanations for them. We did not see higher rates of diagnosis of psychosis, OCD, or PTSD. And this, here again, is especially noteworthy considering the higher levels of adverse childhood experiences in those with PAE or FASD. So once again, we have an indication that in a certain way, people with PAE are doing better than we might expect. And here's where we published our findings on cognition. And the take-home messages here are that PAE was associated with, as you might expect, lower scores on fluid cognition, in the change card sort task, which is a measure of executive functioning, particularly cognitive flexibility. The flanker task, which is measures selective attention and response inhibition. PAE was not associated with lower scores on list sorting, which is a measure of working memory, picture sequencing, indicative of episodic memory, or pattern comparisons, indicative of processing speed. So these results provide evidence that some, but not all, cognitive differences observed in younger individuals are also evident in and may have persisted into midlife. And here's one place where we published findings on brain structure. The take-home messages here are that in fetal alcohol syndrome, we had lower volumes than in fetal alcohol effects, which in turn had lower volumes than the control group in terms of the whole brain or intracranial volumes, and the cerebellum, also thalamic regions and cortical regions. The three groups showed similar patterns of volume changes with aging. And then even controlling for intracranial volumes, FASD had smaller sizes than the control group in volumes of thalamic nuclei, the caudate, putamen, pallidum, cerebellum, and corpus callosum. And there were no interactions of group with age. And so we take this to be evidence of persistent differences in brain volumetrics. And we haven't noticed any evidence of accelerated brain aging in FASD in these studies so far. And finally, this is where we published findings on adult dysmorphology examinations. Just kidding, these are not published yet, but I did present iterative analyses here last year and in Madrid at the EU FASD meeting. Take-home messages here are that PAE continued to be significantly different when compared to unexposed controls, controlling for sex and age. And the cardinal differences remain significantly different. That is, differences in occipitofrontal circumference, palpebral fissure length, philtrum length and lipometer, and vermilion border lipometer. And I want to give a shout out to Mike Seti, who will be talking more about this tomorrow. So, in summary, today we reviewed a broad swath of emerging findings on physical and mental health, substance use, cognition, and physiological characteristics in adults with PAE and/or FASD at midlife. The story here is largely one of persistent between groups differences extending into midlife. And at midlife, we see not only whole body, but also whole person impacts, affecting both physical health and mental health. So far, we're not seeing evidence of accelerated aging at midlife as was expected, but there's certainly more work to be done to unpack that. In several areas, we see ways in which middle-aged adults with FASD are similar to their peers and or doing better than might be expected. I'm not trying to be a Pollyanna here, but I do want to present a balanced view. But more research is needed to continue to develop our understanding of the impact of PAE as affected people age. I do want to note that these findings can be considered kind of preliminary since we are kind of at the leading edge of research here. And I do want to note that absence of evidence is not always reflective of evidence, is not always evidence of absence. So there's certainly more work to be done. So with that, I want to say thank you, acknowledge our funding from NIAAA, acknowledge the wonderful collaboration we share with CFASD, and other sources of funding that you can read for yourself. And I think I might be out of time. Okay, thank you all.
One question.
Oh yes, one question or comment.
Question.
Hi there. Excellent presentation. Thank you so much. Thank you so much. We discussed a lot today about stigma, and I'm curious about how stigma may have affected survey-based studies. So for self-reporting studies such as this, was that a factor or variable that was considered? If so, how can future and further survey-based research best answer or best ask important questions while taking into account stigma that might be considered in the response? Thanks.
That's a really great question. Thank you for that. We did not assess sort of self-perceived stigma, and that would be something I think it would be really important to look at in the future. I think we all should be mindful about the ways in which we ask the questions that we ask, so that we get accurate report in sort of an even-handed way and not bias our findings by making people sort of afraid to acknowledge certain things based on stigma. Okay, thank you so much.